In this video, we'll explore the extrinsic and intrinsic innervation of the heart. To do so, we'll begin by examining how the autonomic nervous system, through the sympathetic trunk, vagus nerves, and cardiac plexuses, modulates heart rate and contractility from the outside. Then, we'll focus on the heart's intrinsic conduction system, including the sinoatrial node, atrioventricular node, and the His-Purkinje network, which generates and coordinates electrical impulses to ensure rhythmic contractions. This integrated control allows the heart to adapt efficiently to the body's needs. We will explore some clinical applications. And finally, a conclusion to summarize all the key points. Let's start with the extrinsic innervation of the heart. The extrinsic innervation of the heart is provided by autonomic fibers originating from the sympathetic trunk and the vagus nerves, which converge to form the cardiac plexuses. Sympathetic fibers arise from the upper thoracic spinal cord segments, T1-T5, and reach the heart via cervical and thoracic cardiac nerves from the sympathetic trunk. They increase heart rate and contractility. In contrast, parasympathetic fibers originate from the vagus nerves, cranial nerve X, and act to slow the heart rate and reduce the force of contraction. These autonomic fibers interweave within the superficial and deep cardiac plexuses, located near the arch of the aorta and the tracheal bifurcation, respectively. Through these plexuses, sympathetic and parasympathetic fibers reach the sinoatrial node, atrioventricular node, and myocardium, modulating cardiac function in response to physiological demands. Let's detail the sympathetic trunks. In the thorax, the ganglionic chain is represented on each side of the vertebral column by 12 ganglia, with the first one being often fused with the inferior cervical ganglion. Each of this ganglia is located anterior to the corresponding costovertebral joint and posterior to the pleura. The sympathetic trunks connecting them is crossed posteriorly by the intercostal vessels. Let's detail now the vagus nerves. There are two of them. One right, and the other left. In the anterior region of the neck, the vagus nerve is positioned posterior to the great vessels. These vessels being the right internal jugular vein, the right common carotid artery, the right subclavian artery, and the right subclavian vein. The right vagus nerve arrives at the superior mediastinum. It then descends along the right side to the trachea to its bifurcation. It lies anterior to the esophagus, posterior to the right main bronchus, medial to the azygous vein. It then moves to the right edge and the posterior surface of the esophagus, with which it enters the abdominal cavity. Moving on to the left vagus nerve. It is also positioned posterior to the great vessels, with them being the left jugular vein, the left common carotid artery. It travels between the left subclavian artery and the left subclavian vein. It lies anterior to the esophagus. It crosses the lateral surface of the left common carotid artery to pass over the anterior surface of the aortic arch. It then travels posterior to the left main bronchus. Moves to the left edge, then to the anterior surface of the esophagus, and then enters the abdominal cavity with it. Now onto the cardiac plexuses. The vagus nerve gives 6 branches, 3 on each side. 2 superior cardiac branches that arise from the cervical portion of the nerve. 2 middle cardiac branches that come from the recurrent nerve. And 2 inferior cardiac branches that originate below the origin of the recurrent nerve. The sympathetic nervous system also provides, on each side, cardiac branches that originate from 3 cervical ganglia of the sympathetic system on each side. The superior cervical cardiac nerve, the middle cervical cardiac nerve, and the inferior cervical cardiac nerve. These nerves anastomoses to form the cardiac plexus. All these branches converge toward the aortic cross, where they interconnect to form the cardiac plexus. The nerve structures that reach the heart form a nervous plexus around the great vessels emerging from the base of the heart. This plexus, called the ganglion de Risberg, is located between the aortic cross and the bifurcation of the pulmonary artery. The left or anterior plexus accompanies the left coronary artery and its terminal branches. It is formed by the superior cardiac branches of the vagus nerve and the left superior cardiac nerve of the sympathetic system. Meanwhile, the right or posterior plexus accompanies the right coronary artery. It is made up of the middle and inferior cardiac branches of the vagus nerve as well as the other sympathetic branches, except the left superior branch. The intrinsic innervation of the heart is governed by a specialized network of excitoconductive tissue that generates and propagates electrical impulses independently of external neural input. At the core of this system lies the sinoatrial node, SA node, also known as the Keith-Flagg node, located in the wall of the right atrium near the superior vena cava. As the primary pacemaker of the heart, it initiates rhythmic electrical impulses that spread through the atrial myocardium. The impulse then reaches the atrioventricular node, AV node, located in the interatrial septum, which introduces a brief delay before transmitting the signal to the atrioventricular bundle, his bundle. This bundle traverses the fibrous skeleton of the heart and divides into right and left bundle branches, which extend into the Purkinje fibers to coordinate ventricular contraction. The vascularization of the excitoconductive system is primarily provided by the right coronary artery, particularly its nodal branches, although contributions from the left coronary artery may also occur, especially to the left bundle branch and Purkinje system. This blood supply is essential to maintain the metabolic demands of the conduction system and ensure continuous cardiac rhythm. The sinoatrial node or Keith and Flagg node consists of a cluster of muscle cells that are larger in diameter than those of the myocardium, with a length of 3 cm and a width of 3 mm. This node runs along the posterior wall of the right atrium, in the sulcus terminalis of his. It begins at the top, beneath the pericardium, on the lateral side of the superior vena cava opening, and descends along the his sulcus. After traveling about 2 to 3 centimeters, it lies in the deep layer of the atrial wall, near the opening of the coronary sinus. The excitation wave originating from the sinoatrial node spreads across the atrial wall, then converges towards the Ascoff-Tawara node of the atrioventricular bundle. The atrioventricular bundle or his bundle originates in the atrial wall, near the coronary sinus. Its fibers gather to form the Ascoff-Tawara node, which then leads to the trunk of the his bundle. Upon reaching the anterosuperior limit of the membranous segment of the interventricular septum, it divides into a right bundle that moves forward, penetrates the ansiform band, and then enters the base of the anterior and posterior papillary muscles where it eventually disappears. And a left bundle that descends along the interventricular septum, then divides into 2 groups of fibers that spread out and extend to the base of the papillary muscles of the left ventricle. The right and left bundles divide toward the base of the papillary muscles into numerous branches, forming a subendocardial network known as the Purkinje network. Finally, let's tackle the vascularization of the excitoconductive system. The Keith-Flagg bundle is supplied by a branch of the anterior auricular artery arising from the right coronary artery, and sometimes from the left coronary artery. The Tawara node and the trunk of the his bundle are supplied by the first posterior septal arteries, which arises from the atrioventricular portion of the right coronary artery. The right branch of the his bundle receives a branch from the second anterior perforating artery of the anterior papillary muscle of the right ventricle. The left branch of the his bundle is vascularized by the anterior and posterior septal arteries. We'll explore now some clinical applications, such as arrhythmias or cardiac dysrhythmias. These result from abnormal impulse generation or conduction within the excitoconductive system. Examples include sinus bradycardia or tachycardia, linked to dysfunction of the sinoatrial node. Atrial fibrillation, due to disorganized atrial activity, often involving altered autonomic tone. And heart blocks, such as first-degree AV block, that causes a delayed conduction through the atrioventricular node. and second or third degree atrioventricular block, that is a complete block of conduction via the His bundle or branches. Neurocardiogenic syncope or vasovagal syncope. Vasovagal syncope is the most common type of reflex syncope, characterized by a transient loss of consciousness resulting from a sudden drop in heart rate and blood pressure, leading to cerebral hypoperfusion. It involves an abnormal reflex between the autonomic nervous system and the cardiovascular system. A trigger such as emotional distress, prolonged standing, pain, or fear causes a paradoxical autonomic response. The parasympathetic system via the vagus nerve becomes overactivated, while the sympathetic tone is withdrawn. This leads to bradycardia via increased vagal tone on the sinoatrial and atrioventricular nodes, and vasodilation and hypertension due to reduced sympathetic vasoconstriction. The combination results in decreased cerebral perfusion and fainting. To conclude, the heart's activity is regulated by a finely balanced interaction between extrinsic and intrinsic innervation. The extrinsic system, composed of sympathetic and parasympathetic fibers, modulates heart rate and contractility in response to physiological demands through the cardiac plexuses. Meanwhile, the intrinsic system, consisting of the sinoatrial node, atrioventricular node, His bundle, and Purkinje fibers, ensures the automatic generation and coordinated propagation of electrical impulses. Together, these systems maintain the heart's rhythm and adaptability, and their disruption underlies many important cardiac pathologies.